Now, next up, your program will say we've got Michael Lau speaking. He is not here. We have Grant Sara, who's almost the busiest man at the conference because he's covering for everyone. I'm not going to read his bio. I'm just going to let him come out. If you want to see his bio because you haven't heard him before, please look in your Symposium book.
Thank you. Thanks very much. Yes, look, apologies. There's been we've submitted a number of papers, and between the passage of time and COVID, other people have had to cancel. So I'm standing in for Michael, and because of a scheduling clash, I'm going to need to duck out immediately at the conclusion of this and go into the next room. So apologies. I might hold off any questions and offer to catch up with people at lunchtime if that's okay too, just for that. And I mean no disrespect to our other speakers by disappearing. How are we going with the slides? Thank you. So look, this is some work, as Andrew said, that is about, that was done by Michael Lau, who's a psychiatry registrar finishing his training and did this as his college scholarly project with us. And it was really wanting to look at the issue of vaccine-preventable conditions, and I just acknowledge the traditional owners of the land we're on today. So, yes, we know COVID has been a really powerful reminder of the importance of vaccine-preventable conditions, and we had done some work looking at, as part of our broader research program, and finding very high rates of vaccine-preventable hospitalisations, which really made us prioritise focusing on that in our ongoing work. But in looking around at the evidence, we found it was a bit patchy, so we thought it would be useful to try and do a review of those questions there. What was the rate of vaccination in people living with mental health conditions? What's the evidence on the rate of vaccine-preventable illnesses and harms? And was there any evidence about the specific barriers to vaccination or specific strategies? This is part of our research program done within the Ministry of New South Wales Health called Mental Health Living Longer, so confusing, I think we were all riffing on the New South Wales Commission's Living Well plan, and going with the Living Longer theme. So we're kind of in a similar territory, but not directly related to the excellent program at Sydney LHD. This is a data linkage program. So what we've done is standard review methodology, looked across all of the available data sets. There's the search, it reflects how long ago this conference was planned and abstracts submitted. Of course, we did this search without including COVID. But we looked across a range of possible studies. We were aware in doing the initial preliminary searching that hepatitis is certainly an area where there's been some literature reviews and some meta-analyses. So we didn't seek to try and redo those. We really tried to focus on what else could we find around those hepatitis reviews. And so the criteria were really about vaccine-preventable conditions or vaccination, and a whole lot of search terms that looked at mental health conditions or mental health services. There is a large literature about potential mental health consequences or neuropsychological consequences of vaccination in children. That was out of our scope. We didn't want to explore that. It's not that it's not an important issue, it's just not our focus. So here's the standard literature review flowchart. After duplicates and exclusions, we found 20, I'm having the same problem that the previous speaker had of seeing that far away, 23 studies that we included in the review. About half from the US, as is often the case, but studies from a range of other countries. And mostly the biggest group were focusing on vaccine-preventable illness. Then there were fewer on other issues. And I guess one of the themes in this is I think that despite this being such a critical area, the evidence is really surprisingly limited, and that definitely anything we can do to keep building the evidence is really critical. So we found 4 studies that looked at vaccination rates. 3 of those were focusing on influenza. And I won't read through all of that kind of fine detail there, but broadly there were 2 types of studies. There was a couple of big US studies looking at large cohorts, and they found actually just slightly reduced rates of influenza vaccination. And then there were 2 US studies, or North American studies, one US, one Canada, looking at groups, particularly quite disadvantaged people living with very long-term illness, and they found very, very low influenza vaccination rates. And there was one study in the US Veterans Affairs system looking at pneumococcal pneumonia and, again, finding only marginal reductions. So certainly in those big US cohorts, lower rates, but only slightly. There was, as I mentioned, quite a body of evidence already on the prevalence of hepatitis and there's been 3 meta-analyses which I've listed there, and they've had slightly different focuses. Some are focused on regional differences, some are focused on gender differences, some are focused on substance comorbidity. To me, the striking thing about them is they all show high rates, but their estimates, their kind of pooled prevalence estimates, are very, very different. So again, pointing to the need for more study. There was one interesting study looking at herpes zoster from Taiwan, finding oddly conflicting evidence with lower risk of herpes in people with schizophrenia, but higher risk in people with affective psychosis. And there's a small group of studies looking at people with respiratory conditions. And I guess we're particularly interested in this issue of respiratory conditions. So those all have very consistent results. So a large study from Sweden, a really useful and important study that we've looked at a lot in the WA study that was done by Mai and colleagues in Western Australia, and also a big UK population study, all found about a 2 to 2.5-fold increase in the risk of influenza or pneumonia admissions. So the studies underline the high risk, but they also underline the limited and sometimes conflicting nature of the evidence on this. There was really only a small number of studies that looked at barriers or enablers. And I guess what they find is that the barriers are the common barriers that when people have been surveyed. There was an interesting survey study of that was done in the ACT at the time of the swine flu epidemic. I'd forgotten about the swine flu epidemic. It seemed like an earlier time. And really what it found is that the vast majority of people who were living with the diagnosis of schizophrenia who were surveyed said they were willing to have a vaccine. They were certainly more, and the factors that drove that willingness were knowledge, perception of risk, costs, barriers, sensible things around which it's possible to see implementation. One of the US studies that was quoted earlier also surveyed people and looked at correlates of vaccination. And their the findings point to both perceived risk, how much at risk will I be if I get the illness, but also the importance of the provider, so that where the recommendation to take up vaccination had come directly from a provider, that a health practitioner that person was dealing with, that people were 4 times as likely to be willing to have a vaccine. So finally, strategies, and there's a number of studies. We were able to identify about 5 trials, including some randomised clinical trials, but also some open trials, really mostly looking not specifically at vaccines, but more broadly at preventative and screening and vaccination. And really, they all find what you would expect, is that any of those strategies that are about improving care and creating more indicated care do lead to better vaccination outcomes. They find that structured, integrated care works, that people are 2 to 3-fold more likely to receive vaccination, and that they're cost effective. One of the models that's been trialled in a couple of RCTs is that STIR model, the screen, test, immunise, reduce risk and refer. But I think there's kind of common themes to most of the interventions. So just to conclude then, that really, I think the thing that COVID has really underlined to us has been that vaccination is about more than stopping people getting illness. That vaccination aims to prevent you getting the illness, but also vaccination has a big impact on modifying the course of disease. So it also means that if you do get the illness and become unwell, you get less severe illness. You're less likely to have those serious harms. And that's a really important outcome as well. that there are strategies that work to improve vaccination rates to get those benefits. And a lot of those are embedded in those broader integrated models. And of course, those also have broader benefits. You know, they're often achieving more than vaccination, but other preventative and screening strategies. And that's important because we know that in terms of that second red arrow on the top there, one of the other big drivers of more severe illness is comorbidity and general health. So if we're getting people vaccinated but also supporting general health, you're trying to intervene at several points in that chain of causation towards severe illness. We've learnt this from COVID, and certainly part of the area I work in New South Wales Health has also been involved in monitoring and modelling COVID data. And what you see here is a bit of a risk matrix where in the way we've looked at COVID data in New South Wales, we've broken data up based on people's age, but also on their medical comorbidities using data linkage. And you can see there is a real interaction between those two. So, you know, that age is important. People, you know, older people have more severe outcomes in COVID, but also younger people with medical comorbidities have more severe outcome in COVID, more likely to end up in hospital, more likely to end up in intensive care and spend longer. And certainly when the linked vaccine data became available, we saw that that's precisely where the effects were greatest as well. So vaccination certainly stopped many people getting COVID, but it definitely meant that people who had comorbidities, including younger people with comorbidities, were less likely to end up in hospital even when they got COVID. And that's a really, you know, I think there's a strong message there for us about impacts. So to conclude, we really need to act, and I think part of that action needs to be to build the evidence. It really is surprisingly patchy, and Patrick Gould and Phil Ward at South East Sydney are doing probably a detailed and more rigorous review that will be really useful because the evidence is limited. But in terms of what I think we need to be documenting the harms with some of these epidemiological and linkage type approaches, and even when we're doing local implementation of a vaccine rollout, the evidence is so small that anything we can do to document those and get that evidence out there would be really useful. And part of that is also that information sharing through things like Equally Well. We really do need to have strategies that address those specific conditions, hepatitis, respiratory illnesses, and some of the conditions for which there's vaccines in older people as well. We need to try and address some of the barriers and costs and health system barriers. And I think that strong message about trying to support broadly general health as well. So, look, thank you. I'll acknowledge my colleagues, and again, Michael Lau, who did this work. So thanks very much, and apologies for the haste.